Welcome, everyone. Thank you so much for being committed to this conference, that you would come to the last session on Tuesday when really that pool is just screaming your name. So thank you. We had 60 people show up or that registered for this presentation. So you guys are A's automatic get A's. So thank you so much. We really do appreciate this, and we are very excited to present this information to you. And this is something that will explain how it came up, but just really excited and just another way to look at what's happening with our kids. So my name is Kari Kuka, and I am the supervisor of a reproductive health education program within the Denver Health School-Based Health Centers. And I'll explain what that looks like a little bit later. I've been in the field of reproductive health for about 15 years, working with anywhere from middle school kids, Girl Scout troops, heroin addicts, HIV, STDs, you name it. I have probably worked with that subgroup. Parents, lots of parents, college kids, high school kids, middle school kids. So thank you again for coming, and this is Wanda.
Hi, I'm Wanda Partial, and I'm going to stay here to introduce myself, but then we're going to tag team back and forth. I am a pediatric nurse practitioner and have been with the Denver Health school-based clinics for almost 4 years now, but I have been doing school health off and on since 1998 and working with adolescents, and some of my experiences that came through this presentation were actually in an adolescent clinic in Iowa. I would like to welcome through the online streaming our mental health supervisor who could not be with us. Jennifer Koch is our mental health supervisor for our clinics. She's sitting back in Denver in 104-degree weather. So she is with us and has been a great support for us when we've done this presentation.
All right. We have no relationships to disclose. None. We would like to remind you that this presentation was selected to have a live stream, so we may get hopefully a question from a tweet if whoever's in the room is monitoring the tweets. So I'm really excited about that. But also, if you have questions, instead of just raising your hand, we're going to ask you to go ahead and stand up at the microphone to ask the questions. So let's get started. What are we going to learn today? So these are the objectives that you'll find in the write-up, just a little bit more circular. So we're going to talk a little about the Denver Health School-Based Health Centers and the Reproductive Health Education Program and the mental health and how we collaborate within Denver Health. What comes first, the chicken or the egg? Are we talking about depression in teens who are more likely to get pregnant, or the pregnant teens who are more likely to get depressed? Risk factors that correlate with teen pregnancy. Some of these, you probably know these, so we're going to run through those. But some really cool information that we found that correlates with teen pregnancy as well. Contraception and depression, a little bit more in depth about, wow, have you ever read the fine print of these medications? And then how to incorporate all of this together. And I do know that some of you aren't as blessed as we are in Denver to have all these different areas to refer to. You may be all of them in your clinic. So how to work together and incorporate that. All right, little group participation. Who in here is a clinician? Wow, a lot of clinicians. Awesome, thank you for coming. Do we have any health educators in here? Woohoo! Shout out to the fellow health educator. All right, mental health. Some mental health peeps too. Great, this is the mental health track, so I'm happy to see you. Anybody else? Community-based organizations, anyone community-based? Awesome, thank you so much. So that gives us an idea of who we're working with. Great information for you all. So I'm going to let Wanda talk a little bit about Denver Health.
Thank you. You're going to hear about our system a little bit, just to give you a perspective of later as we look at the collaboration amongst ourselves, well, what are you guys talking about? Because I know different school-based clinics have a different structure. As of August of this year, we will have 15 clinics in the Denver public school system. So we're growing faster than I care to recognize some days. 7 are in high schools. We have 2 that are 6th through 12th grade. We have 4 middle schools. And we have a couple that are kindergarten through 12th and actually ECE. I did put there that we have some feeder elementaries. That means we have elementary schools that are not where the school health center is, but they can actually come use those services. So we didn't quite reach 9,000 users this year, but we got close. That's our goal. And we had over 32,000 visits. So the services are very similar to what you're used to in a school clinic. We do risk assessments, physicals, much of that. Each of our 15 clinics does have a mental health provider. Not always full-time, but we do have a mental health provider at least 3 days a week in all of our clinics. And I know Kari's going to go through the reproductive health education program a little bit in more detail. But those are kind of encompassing some of the services. And I'll let Kari talk about her program.
Okay. So in 2007, we were lucky enough to get a grant to fund a reproductive health education program. So currently, we have 7.5, because I'm the supervisor and I serve in the clinic 2 days a week as well, that serve 14 of the 15 school-based health centers currently. And our job is, and what we do is we use a science-based curriculum called tailoring. Has anyone heard of tailoring? To meet the needs of the teens' family planning? No? Okay. So it's a clinic-based, science-based curriculum that works with a one-on-one counseling, motivational interviewing is what we do. Client-based, client-centered counseling. So an example, a student comes in, they meet with me, it's determined that they're thinking about becoming sexually active, they've already started to become sexually active, they think they're pregnant, they've had a negative pregnancy test. We talk with them about, hey, why do you think now's a good time to have sex? Okay, excellent. Sounds like you've really thought about this. You're ready. All right, how are we going to prevent you from having a baby? Okay, is that something you want right now? Some of the girls say yes. So this one-on-one, then we refer back to the clinician for some contraception. Just a side note, right now in Denver Public Schools, we are not allowed to dispense except at one school. And it's a local, principal local control. This next year, we hope that's going to change. But right now, only one, so we're referring all of our kids out for contraception. Just my program, the 7.5 health educators, we were able to reach 3,200 unique patients, 6,400 visits. So we're pretty busy, and we're functioning in middle schools and high schools. So we see 6 through 12, doing a lot of puberty, basic education about bodies, feeling really good, relationships, and so forth. So my program, we call it a reproductive health education program, but I also call it positive youth development because we're really hitting all those points as well. All right.
So our mental health services are not all provided by our Denver Health program. We have a collaboration with the Mental Health Center of Denver where they actually provide services in some of our clinics and we provide the rest. And I showed you the breakdown there. The Mental Health Center of Denver has a little bit more as far as their process for their intake for their clients. That is one of the differences. Otherwise, they are clinical licensed social workers, therapists that work in the clinics. What we do, what our priority is, and those of you that are mental health therapists, kind of let us know where you're at. We work on a pyramid model where the bottom of the pyramid are those students that have some behavior problems. They act up in class, no major psychological problems, no major mental health illnesses. Whereas at the top are your most severely mentally handicapped students who really need a lot of intensive work. We use our own therapist in our clinics for that top of the pyramid. So we're dealing with the most critically mentally handicapped students. Whereas that student that's just behavior problem in class, we leave that up to the school social worker, the school psychologist, whichever, that school happens to have. So there's a team approach with that where they're deciding, okay, who comes to the clinic mental health therapist, who goes to the school social worker. Our clinicians use a risk assessment where we're asking some of the questions, and we ask about all risky behaviors, but we're asking specifically 2 or 3 questions that will lead us to think that the student is depressed. We use a PHQ-9, and we actually have a database, which is called our Depression Collaborative, where we enter all of these students who have a PHQ-9 greater than 5, which indicates some depression. We put them in a database, so we're following them, finding out what services they're using, so we're actually tracking our depressed patients. We do have a Denver Health child psychiatrist that works and comes to the schools. If you kind of think that we're doing the top of that pyramid, we really need that psychiatric support. And she spends time in each of the clinics that have a Denver Health therapist. Okay?
Now we get to the good stuff. So that's who we are. That's what we do. That's kind of our system. So if you think about a clinic, on any given day, we have our healthcare partner, our clinician, our mental health therapist, and our reproductive health educator in the clinic. So that's kind of how Denver Health is functioning. So what comes first? Do we have the teens that come in presenting as depressed who think, oh, I just want some unconditional love. I just want something to love me unconditionally, right? I think I want to get pregnant because she's depressed. Or do we have the girl who got pregnant and is coming in saying, I'm really depressed. I didn't mean for this to happen. So that's kind of where we came to this conclusion of let's talk about this. Let's really start recognizing, and for the girl who says, I don't want to get pregnant right now, I want to have fun, why is she coming back saying all of a sudden she's depressed after we gave her a contraceptive method? So that's what we're going to talk about. So here's a story. This is a story of, we'll call her Regina. Okay? Regina saw our mental health therapist for about a year. She was doing great. She was on her antidepressants. She felt great. Home life had changed for the better. Things were super fantastic. She also got in a relationship. She came and talked with the reproductive health specialist. Everything was great. A few weeks later, she came in really distressed and said, I need to see the mental health therapist. So she came back with the mental health therapist, and actually she was suicidal. We had to put her on a hold and get her to the hospital. What do you think happened? Any ideas of what could have happened to this girl to get her to that point of suicide? Okay, great. We had someone just said she got a boyfriend, now she found out she's pregnant, and now she's suicidal. That's not what happened, but that could have very easily happened. The only thing that changed was we gave her a Depo shot. Yeah, we gave her a Depo shot. And it took some work on the mental health therapist's point to say, gosh, what's changed? Did something happen at home? Everything's fine at home. What happened with your boyfriend? Everything's fine with my boyfriend. I just don't feel like doing this anymore. And so really talking and discussing, and this is when we decided to present this program. The mental health therapist came to me, this has actually happened at my school, came to me and said, hey, is depression a side effect of Depo? And I said, well, I don't know. I think it is, but let me check. So I started reading the fine print of our contraceptive methods, the little insert that goes along, and realizing, wow, depression is actually right up there. So Wanda and I started engaging in a conversation about, should we start asking our patients if they've ever been diagnosed as clinically depressed before we put them on a method? But then we said, wait a second. What are we doing here? Do we want to really keep a depressed teen from being on contraception? Not really. So that's what brought us here today. I mentioned this before. If you have a girl who's a young mom, that's a red flag that she might be depressed. If you have a young girl who's depressed, that's a red flag she might want to get pregnant or become pregnant or non-compliant with her birth control because she's depressed. She doesn't care. Okay? These are the things you probably already know. So we're just going to swing past these. Low parental education is a risk factor for teen pregnancy. Of course, a repeat, if your mom was a teen mom, you have a higher chance of becoming a teen mom. As that in the opening plenary session yesterday, they were saying, you know, we could have a great grandma at 45, right? 15, 15, 15. That's kind of scary if you think about it. Who wants to be a great grandma at 45? We have people who are becoming parents at 45 for the first time. Being African American or Hispanic, what we didn't say is that a large majority of the population in Denver school-based health centers is Hispanic. That's our largest population. Low grades, being depressed, and then violence, teen dating violence, violence in the home, and so forth, gang-related. This is on the CDC website. Has anyone ever seen this before? Sexual activity correlated with grades? Interesting. I love this slide, and I use it all the time. So it's on the CDC website. It's also in your reference slide, so you have this information. Sexual risk behaviors. Have you ever had sexual intercourse? Let's go to the percentage. Those are percentages. 32% engage in sexual activity if they have straight A's, 32%. If they have D's or F's, that shoots up to 69%. Interesting. Those are the ones skipping to have sex. So they're skipping class and getting low grades. Ever had sexual intercourse for the first time before 13 years old? Goes up to 18% for D's and F's. So this is very fascinating. I'll let you guys look at your chart. But really looking at, these are the kids that a lot of times, did anyone attend the research on does school-based health centers help academic outcomes? So I was sitting in that presentation thinking, hello, yeah, we're seeing a lot of the girls with the D's and the F's because they're coming in, they're ones getting referred by the teachers, and if you're a teacher or a clinician, asking about grades. What are your grades? What's going on at home? Because they're also more likely to be depressed and less engaged in class. Okay. Adolescent girls in physically abusive relationships were 3.5 times more likely to become pregnant and show symptoms of depression. We know this, right? If you don't have a self-esteem, it's hard to stand up for yourself in a relationship or even get out of a relationship. We're having pregnancy coercion. I want you to have my baby. I can't tell you how many times I've heard that. My boyfriend wants me to have his baby. Have you watched 16 and Pregnant? My boyfriend wanted me to have his baby and then he left me. Okay? So they're being coerced into getting pregnant because the boys are saying, hey. They're also, we didn't put a slide in here, but it seems relevant. Sexting, anyone having a problem with sexting? There's some data out there that says 25% of girls have either sent a semi-nude or nude photo. Okay? That's coercion. They're being coerced into doing that a lot of times. So really important things to think about. I'm going to hand this next part over to Wanda.
So we're going to talk a little bit about depression in teens, and you're going to see the connection between all of this. Because kind of keep in mind, when we put up that chicken or the egg, there's no answer here. One doesn't come before the other, and one isn't exclusive of another. Just to look at the incidence, and those of you that are mental health providers know this probably better than I do, but the lifetime prevalence can be as high as 20% among teenagers. Actually, the 6 to 12-year-olds, the statistics are 1 to 2%, but then once you hit 13, 2 to 6%. It goes up dramatically once they get older and into high school. Keep in mind that suicide right now is the third leading cause of death in teenagers. So something we don't want to happen. You might think, well, the incidence is pretty low of these teenagers on contraception of getting depressed. Well, you don't even want one of them committing suicide. It puts them at a higher risk as they go into adulthood for being depressed, and actually 50% of them don't even receive treatment until after their 18th birthday. They're living part of their young, active life being depressed. So I like this slide in that this is going to make you start thinking about the two together. It comes from the 2010 Youth Risk Behavior Survey on the left, on the amount of sexual activity that's out there. By the time you're a senior in high school, there's a really good chance you've had sexual activity, 63%. Then start thinking, the lifetime prevalence of depression is 20%. So how many of those 63% seniors are depressed? And what's the cause and the relationship between those two? So now we're going to go into the meat of this one. Probably what you came here for. You're thinking, oh, I put all these girls on contraception. What am I doing? And that's actually what. I also have a story, and then I'm going to talk about the research a little bit. And this came from one of my adolescent clinic years. I had a patient that, believe it or not, her mother brought her in to get her on Depo, not because of sexual activity. She was a dancer, and she was 5'10", and her mother did not want her getting any taller. That was her reason. I tried to talk them out of it, but she was bound and determined her daughter was going to be on Depo-Provera. I think there were some underlying currents that she also didn't want to become a grandmother. So whatever their reason, this girl started on Depo-Provera. By the time she came back for her second injection 3 months later, I could see there was a difference. No eye contact, she wasn't doing as well in school. She wasn't as excited about her dancing. And I'm like, what is going on? And we kind of talked, and I said, I want you to come back in a couple weeks. And sure enough, her mother brought her and says, I think she's really depressed. And the only change, again, was her Depo-Provera. We switched her birth control method, but come to find out there was, and I'm going to talk later about the other factors that were influencing that, but she did better. We did put her on antidepressants, and she was the prima ballerina for the Nutcracker that winter. So it was a nice success story, but could have been disastrous. What you will see out there, if you look at the studies on contraceptions and depression, is there's nothing definitive. There's nothing significant. Keep in mind the studies that were done. There was a small random control trial that was done with combined oral contraceptives. Again, there wasn't any significance. Doesn't mean it wasn't there. It just didn't statistically show significance. They also did it for Depo-Provera, and again, the statistics were not significant. That is why the WHO review doesn't include that as an eligibility criteria if they have a history of depression. It is not a reason to withhold contraception, and we're for that. Don't withhold it. You don't want this depressed girl getting pregnant. So we're not here to say, don't do it if they're depressed. There's some caution you need to take. So what we did is we started looking at the package inserts. How many of you really have the time when you're giving out birth control to pull out that package insert and read the fine print? Yeah, I don't have time either. I'm seeing a lot of kids when I'm in clinic, so trust me. So that's why we put this together. We want you to see what is written in the fine print. So on most pills, it's listed as mood changes. Interestingly enough, when they did one of the studies with girls on oral contraceptives, they asked them, well, what is the biggest side effect that you're afraid of? Mood changes. A third of the girls were afraid of mood changes. Now, not that many actually experienced it, but that is out there. The girls are afraid of that when they go on oral contraceptives. The patch. On the patch insert, it's listed as emotional liability. Still the same incidence as oral contraceptives. It's the same hormones going into their body. It's just interesting how the manufacturers have decided to list it. And then Depo-Provera. Depression is listed as a side effect of Depo-Provera. The progesterone in any of the contraceptives is what has the higher incidence of having depression as a side effect. So keep that in mind. Any of those contraceptions that have a higher progesterone level or are pretty much all progestin, those are the girls you want to really keep tabs on a little bit closer. We looked at Mirena. Mirena has mood changes listed as a side effect. Okay. And we looked at Implanon. Again, it's listed as mood swings more frequently than depression as far. And we have even, this is actually from the Implanon insert. And it just basically says, women with a history of depression should be carefully observed. Consideration should be to removing. How many of you ever want a girl to get their Implanon removed? I don't. I do anything I can to keep that Implanon in. But here, it should be considered to take it out if they are significantly depressed. So, and switch to a different method. This is on the Implanon insert. And I put arrows. Mood swings, and this is the rate. So 1 in 15 girls will have mood swings, and 1 in 18 are listed as clinical depression. That's quite a few. I mean, I don't know about you, but we're seeing 10 to 15 students a day in our clinics, so the 1 in 18 can hit about once every few weeks, if you're not careful, of those that have Implanon.
And I just want to point out the pain at insertion site is usually what they're talking about, right? Oh, I got a really big bruise or it hurt really bad when I got my Implanon in. That was 1 in 19. So I just thought that was really interesting on the insert.
And this again is on the Depo-Provera insert that, and it's listed under CNS disorders and convulsions. So you might not even, just glance through that. But it basically says patients who have a history of psychic depression should be carefully observed and not have it readministered if they're significantly depressed. And again, we're not saying don't give them contraception. You need to look at a different method, possibly. And again, Depo-Provera listed as a side effect that occurs 1 to 5%. So over the course of a school year, more than likely, I know we have only one clinic where we're dispensing, but I will tell you we have at least 50 girls on Depo-Provera. So in 50 girls, 2 of those could have depression when you really look at those statistics, okay? So keep that in mind.
We have 100 on Depo in that school.
Oh, I was being conservative. So. And then the NuvaRing. Actually, NuvaRing, even though it has some of the same hormone components that oral contraceptives does, the patch does, they do less mental depression as a side effect in their insert. This was it's kind of a busy slide, so I'm going to go quickly. But it's to kind of keep in mind that every person deals with drugs in their body differently. We look at the dynamics, what the drugs do to the body and how, and of course we want those contraceptives to cause the girls not to ovulate, those types of things. But then when you look at the kinetics, how that is distributed and excreted is very, very individual by each girl. So one person on depot that becomes depressed may not be as depressed as the next one on depot who is depressed. So it's going to be very individualized, but that's what we do for a living. We treat these students on an individual basis. Okay. I'm a very big Calvin and Hobbes fan.
So now what do we do? So we're looking at these teen girls. We don't want to allow them to get pregnant if they don't want to get pregnant. We want to be able to freely dispense contraception, right? Or give them the opportunity to start contracepting if they want. But we're also concerned about depression. And we know that there's a lot of girls that have, depression up and down, right? My boyfriend broke up with me, my grades are not going very well, and so forth. So what do we do? Do we stop giving contraception? Do we give antidepressants and condoms? Maybe. Yeah, absolutely. And then that contraceptive method, right? We want antidepressants, condoms always, and then a contraception method as well, to get them to where they are happy contraceptive users, right? So that's where we're looking at, is we really want to bring this to your awareness. We also want to know, I'm really into social norming. The norm is most girls do fantastic on their contraceptive method. So I really want to put that out there, that this is not happening all the time and that we really need to have a heightened awareness, but we do need to have an awareness. So as a reproductive health educator, I want to really, when in our program we follow up with these girls at 1 month, 3 months, 6 months, and I'm going to start, how's everything going? And when I start recognizing, you seem kind of depressed. What's going on? Oh, you've had 2 depot shots. You're still with the same boyfriend? Everything good? Yeah, everything's good. Okay. Then I'm going to start wondering, okay, is this the time to refer to a mental health therapist? Or is it time to refer to the clinician? To say, hey, maybe we need to get on a different contraceptive method. I'm not a clinician, so I can't make that decision. But I do want to talk to the girl and say, is this method working for you? Is this the one that you really want, or do you want to try a different method that maybe has a different hormone balance? Oh, and then, I knew I had a note. And then we really want to find out, how many people have just come out and asked a teen, hey, tell me why you think now's a good time to have sex? How many people are brave enough to ask that question? Okay, I love this question, okay? And I didn't ask it for the longest time. I was just like, oh, you're having sex? Okay, let's talk about contraception. I wasn't asking, why? Why now? What's going on? And what I unveiled through that question is that these girls aren't having sex necessarily because they want to. Why do you want to have sex right now? Oh, well, my boyfriend wants me to. Okay. What do you want? Well, I want to wait. Oh, okay, because I can help you wait. I can figure out a plan to help you wait longer, right? So I encourage all of you as clinicians, mental health therapists, as health educators, as community, when you come in contact with these teenagers, one, we do not want to assume they're having sex, okay? There's a lot of kids out there that are not having sex yet, and I love those kids. But the ones that are, we need to find out, because I had a whole lot of kids that returned to abstinence again. They did it once, they didn't like it, it hurt, they didn't like it, they weren't ready, and then we made an abstinence plan. So really getting in there and asking the question, not like, why are you having sex, girl? We don't want to make it seem accusatory or mean, but tell me why you think now's a good time for you to have sex, I had a 13-year-old tell me that she wanted to be a mom, and I said, oh, so you think 13-year-olds make good moms? And she was like, oh. And we talked through it. I'm motivational interviewing with her, right? I'm client-centered. I'm meeting her where she's at, and she thinks that she's going to be a good mom at 13. So we talked through it, and guess what? She left with a depot shot. Okay, so really, that's what we want to stress as well, is that if they're having depressed, if they're having home life issues, we really need to ask the question of, let's get through this first, and then move on. Okay.
And this is more for some of the clinicians, but I'm just going to kind of tap on what Kari was saying. I had an 8th grader last year that was sexually active, and I'm kind of like, okay, so why are we sending you off to get birth control? Is there a reason you decided to become sexually active? Yeah, I'm mad at my mom, and I want to get her back. She went to the mental health provider. So kind of keep that in mind. But then when you truly have a girl in front of you who is sexually active, needs to be on contraception, you're asking lots of questions. The one you really need is that last one. Do you have a family history or a personal history of depression? I mean, we ask about, do you have bleeding disorders? Do you have clotting disorders? Do you have headaches? Do you get migraines? We ask a lot of those, but you also really need to make sure you're asking about depression. And then I started also asking, what worries you about using contraception? Of course, the girls on depot, I'm going to gain weight. Not always the case. But, really get out. What are you worried about? Because then if they say, oh, I'm worried that I'm going to have mood swings and mood changes and things like that, you can come back and say, no, that's the rate of that is fairly minimal. Get that in their head before they even get started on that. Because that way they're going into it knowing that the incidence of having mood swings is not as high as what they're worried about. But I think also to keep in mind as they start on that contraceptive method, it's part of my job as a clinician to say, if you have any changes that you're worried about, I want you to come back and see me. So that just kind of gives you some ideas. So the one thing I want to ask you as a group, how many people in your clinics do have health educators that are working like with Kari? Just a few. Okay. And how many of you have mental health available to you? Good. Quite a few. So the whole summary of this is to really look at, in your clinic situation, how can the mental health therapist, the clinician, and the health educator work together? So this is, I know it's getting late in the day. Everyone is ready to either eat, take a nap, or go to the pool. But what we want you to do is turn to the people in front of you or behind you and talk about these things that we've listed up here. You have girls on contraception, whether you do it yourselves or whether you send them out like we do to get it from elsewhere. You still have girls on contraception. What instance with that girl would you send to the mental health provider refer back to the clinician? When would the clinician refer to the health educator? What instances does the health educator refer to the mental health? When does mental health refer to health educators? And when would the health educator refer back to the clinician? And then, of course, the clinician referring to mental health. Get some good, solid examples, and we'll give you about 5 to 10 minutes just to kind of work amongst yourself, and then we're going to kind of do some sharing. The one thing that I've always enjoyed about this conference is the amount that I learn from other clinics in the networking. So we wanted to provide that for you. So you got about 5 to 10 minutes, and then we'll come back.
I think that's great. Well, Uh-huh.
Yeah, that's good.
We'll give you guys one more minute to wrap it up.
So, do you want to just start filling on the list there? Just ask. I mean, now we might have them.
Okay, I'm going to bring you guys back. Sounds like we've moved on to some greater, more fun conversation. So, if you have an answer to my question, if you wouldn't mind stepping up to the mic, that would be great. I encourage every group to share. So let's just go ahead and start with, who came up with an example of when does mental health refer to a clinician? Yeah.
Don't be shy.
Don't be shy.
Pregnancy testing.
Pregnancy testing. So let me just clarify. So if a mental health person comes across a student who is in talking with the mental health therapist going, I think I might be pregnant, absolutely. Refer to the clinician. Let's get it out of the way so we can get to work if you're not pregnant and so forth. Great. When does the clinician refer to the health educator? This one's a tough one. Clinicians? There's a lot of you in here. When would you refer to a health educator? Be brave. Be very brave.
Okay, I got one. Let's say I'm going to put a girl in depot, and her concern is her weight. Refer to the health educator and make a good plan on how she's not going to gain weight.
Fantastic. Absolutely. And we do a lot of that, and relationships come up, right? We also talk about, in my reproductive health program, a lot of times the clinician is, the minute the girl comes in for a pregnancy test, the clinician refers to the health educator because they don't want to take the hour to explain every method and how to use every method and so forth. And then it's a circle effect, right? And then we send them right back to the clinician once they've decided what method. A lot of clinicians, when the program first came about, a lot of the clinicians were like, but that's my favorite part. right? So it took them a while, but now the clinicians are begging me, please don't take my health educator away, because they've seen how beneficial it is for the students to come back to them and say, oh yeah, miss, the lady in there told me all about Depo, and I just need to drink some more water and not eat all, 2 bags of Cheetos and, the hot and spices that they serve at lunch. So I'll be good on my Depo, and yeah, when my implant on, they told me I could come back to you and treat the bleeding. It's cool. You guys have a plan. So the clinicians are like, yeah, that's great. And I didn't have to spend an hour. I can see more kids. All right. When does a health educator refer to mental health? Where's my fella health educator? When would you refer to mental health? Yes, please. For our guests that are online with us.
I guess I would refer if they had any thoughts of suicide or any type of depression, feeling down, having any troubles with relationships, school, anything like that.
Great, a lot. I'm going to give you one more example that I've run into. I had a gal who was 13, and she was referred to me by the Denver school-based health center, the Denver Public Schools social worker. And she said, hey, would you mind seeing this student? She got caught making out with her boyfriend in front of the school. So I brought her in and said, hey, what's going on? You dating anyone? All this stuff. Well, I ask a series of questions that are confidential, but it's for my evaluation of my program. But I ask questions, are you interested in boys, girls, or both? What kind of sex are you having? You having oral sex? You having anal sex? Asking the really good, juicy questions. When she told me she was 13 and she's had 5 partners, that to me is a red flag that there could be possible sexual abuse in her previous history, that things aren't going so good at home. That's an automatic red flag. As the health educator, I'm referring to mental health. Automatic. Because I know 13-year-olds don't have 5 partners. 13-year-olds have 1 partner and decide they don't like sex, right? So automatic red flag. So there's a lot that you can train your health educators, if you have health educators, on to be aware of when asking these questions. This is really important to identify when do you refer to mental health, because I don't ask, are you depressed? But I ask, are you having fun in school? What does that look like? Are you in school? Did I pull you out the day that you came this week to school? So really good, but absolutely a lot of family stuff comes up. I've had, unfortunately, a lot of tissue boxes in my office because we're this close having a conversation, and all of a sudden it triggers this emotional, and it's like, what's going on for you? What about that question triggered these tears? What's going on? My mom wants me to get married, and I don't want to get married. I had a sophomore in high school, and mom wanted her to get married to get her papers. Big stuff, so that's a referral. All right. We have a mental health therapist. When do you refer to a health educator? All right, Monica.
Basically, every intake that I do, I refer to the health educator. If they tell me they're in a relationship or if they tell me they've had sex in the past, I'm like, okay, have you met our health educator? Let's go across the hall right after to do a meet and greet.
Fantastic. I love her.
Monica's with our program.
Monica's with our program at Denver Health. She's a mental health therapist at one of our school and had 80% time reproductive health educator on her site. And that's exactly right. Every teenager benefits with a visit to the health educator. We're talking about relationships, how to abstain from sex. Those are a lot of things that clinicians don't necessarily have time to do because you're doing a sports physical. They just want to play sports. So we're asking the questions of, hey, you just got in a relationship for the first time. Have you guys talked about sex? Is that something you want to do? What's your sex plan? I love that question. What's your sex plan? And they're like, what? I haven't made a plan. Oh, well, you need to make a plan. What's your plan? And they're like, well, because I said, I don't want you to come back and say it just accidentally happened. We need to have a plan about sex. And it's like, oh, yeah. I'm actually training their frontal cortex, right? because I'm making them critical think now, right? As for those of you who are in the teen brain, right? Training the brain. Okay, so clinicians referring to mental health. This one sounds self-explanatory, but give me a real juicy one. When do you refer? You're doing a sports physical. When do you refer to mental health?
There's a lot of clinicians here, so somebody, come on. Oh, you guys are too quiet.
All right, I'm going to have to call on someone. Okay, thank you.
Well, I'm a mental health person, but I've gotten referrals when we had a 13-year-old, for example, who wanted to have a baby.
Perfect.
And so I got that referral. I get referrals if somebody finds out that they are pregnant, and then if they want to come to counseling, and a variety of other things, but depression and all of that. So.
Great. Thank you. So I hope this was helpful to really start identifying ways to utilize each other in the clinic. Okay, we definitely don't want to have a silo, and we try to have, if a student comes in for a sports physical, we try to get them to as many resources as possible that they may need. We're dealing with the whole student, right? We want to meet them where they're at, and if they're a bit depressed, we want to catch it early. And talk with them about that. And so we have a great system and referral process. I know some of you may be the health educator, the clinician, and the mental health therapist all in one. I do know that. And so really putting those different hats on for these students to be able to open up and have you as the trusted adult in their life that they can come to with any question.
The one case, of course, is the girl on depot that gets depressed. You are going to use each and every one. If you're going to switch her depot, I send them back to Kari and say, here you go, talk about different methods, okay, because we're taking you off of this one. You need to go over and see Monica because Monica's our mental health person and she's going to deal with your depression. But you need to come back and see me and get on a different method and maybe an antidepressant besides.
Yeah, so we're really working in a circular motion, making sure that we're getting the student all the resources that they need for that. And I just love this this picture of this little baby, because this little baby doesn't want a depressed mom. He told me. Any questions? Anything bubble up for you? Great.
Okay. During your presentation, I was thinking, so a lot of times as a clinician, we are seeing someone with mental health issues and, of course, medical issues. I'm just wondering what others would say. Is it helpful to bring them in more often and deal with one issue at a time? Or do you feel like some things get lost if you try to deal with both in one visit? I'm just curious what other people think.
Great question. We can open it up. I will tell you, and this comes from my years ago when I was GAPS trained. How many people have been trained in Guidelines of Adolescent Preventative Services? The one thing that you're taught then is to take the most critical issue and deal with it then and then bring them back for the next one. But what are you going to do when you have a girl that needs contraception and is depressed? We don't want her killing herself. We don't want her getting pregnant. So you almost have to deal with both issues and prioritize, but then absolutely have them come back over and over again. Anybody else want to make a comment on her question? You guys are quiet.
Are there any other questions?
I have a comment, and I'm sure we all run into this, is that, we want them in class, and the school wants them in class. So it's a delicate balance for all of us, obviously, to meet their needs and see them as often as they need to be seen, but at the same time, don't have them out of class too much. So I think it's really important for the people on the team to really work together to sort of figure out how that's going to work. If the mental health provider is seeing this girl on a regular basis and I just need a blood pressure check, I'm going to get that blood pressure when she's in seeing the mental health provider.
Good point. Mm-hmm. And we're very fortunate in that most of our clinics, most of them, not all of them, but these people are like within arm's length. So you're right. They come to see the mental health therapist. Oh, but I need my blood pressure checked. Okay, go just down the hall and see the medical assistant who's going to do your blood pressure check. I all the time at the one clinic where I practice the most, the health educator has been right across the hall. So I finish with my sports physical, and I'm like, okay, open the door, knock on Sarah's. Here, Sarah, you need to talk to this person. Very briefly. And we're really big on not keeping them out of class also. So what Sarah may do is say, okay, when is your next elective? And I want you to come back and see me today yet. So we're still taking care of all those needs in an urgent way, but trying to keep them in their core courses is what we really attempt.
Can I say one more thing?
Yep.
And I think that's so important because you're bringing them by and introducing them. You know, then they're going to be more likely to come back because they've made that. You've sort of made that bridge and have had that face-to-face contact.
I'm just going to touch on that too. Going back to that slide with the grades and the sexual activity, the kids that are getting the D's and the F's are also the ones that are usually the frequent flyers in the clinic because they're depressed. They've got home issues. They need contraception because they're ditching school to have sex. So we're really struggling. The teachers are like, oh, she's flunking. She needs to be in class. Why does the clinic keep pulling them out of class? And so what we need to do is to get them healthy and then get them to class, because they're not going to go to class if they're not healthy, right? And we know that they're not going to go to class if they're pregnant with nausea and morning sickness. So it's really that delicate balance. The ones that need to be in class the most, the straight A students aren't the frequent flyers in our clinic. So it's really that I understand the balance because we work with our teachers too. So it's very important, that balance. What other questions can I answer or Wanda can answer about clinical guidelines or situations? Anything about the reproductive health program? Anything? Thank you okay, perfect.
I was wondering, do you know statistics on the correlation between the history of depression in kids' family and in the youth's family and them developing depression with a Depo shot? Is there a high correlation with that, or is it kind of just we're thinking that's a good idea to ask?
Well, there's not really, good question.
Yeah.
There's not really research out there that's shown that girls that come from a family history of depression have a higher incidence. I think it's more that it's documented over and over again that those girls actually do run a higher risk. It's just that we don't have the evidence yet.
And I was also wondering, do you, often it kind of comes to my mind when we start a youth, or even I work with some adults on an antidepressant, and we kind of go through the risks and all of those things. Is that something that you're starting to do with Depo shot to say, okay, if you actually start to have suicidal thoughts, this is a crisis line you can call, and all those kinds of things, sort of as if you're starting some other
it's a delicate balance. Yeah. And the reason for that is because the seed you plant will grow. Right? So if you plant in a girl's brain that she could get depressed, she might have a heightened awareness like, oh, well, I'm having a bad day, right? So it's the seed that you plant. And so I think that it's really good to make sure when you follow up or at the next visit when they come back, how are you feeling? Have you noticed any difference in how you're feeling? Versus, are you feeling depressed? How have you been in the last 3 months? Are you depressed? Okay, because then they might be, well, yeah, I did have a couple days where I was depressed. My mom wouldn't let me go out and party. I was depressed. So asking the question the right way to really get the answer and let them think about how they were feeling is I think, a better approach than to just plant that seed. So that's a fantastic question, and one that Wanda and I went into her office and I'm like, should we be using this as a contraindication for Implanon and Depo? And I'm really concerned because I was really concerned about this girl who became suicidal on Depo. But I also had another gal who was on antidepressants and doing very well, and she got an Implanon and she became depressed even while on maintaining her antidepressant. She switched to Depo, and she did very well. And so we don't want to rule out, we don't want to go to combined, right? Because every person's different. And so, okay, we know that Implanon didn't work for her. Depo did. I would have never thought that would be the case, but it worked for her. So,
And I think your question had to do with someone that was already on antidepressants too. And the important thing, and that's what school health is so beautiful about, is the follow-up. It may not have to be a long visit, but if you put someone on Depo-Provera who's also on an antidepressant, I want to see you back in a week. I want to see you back in a couple weeks. All I'm going to do is touch base and see how you're doing. I'm not going to say, and see if you're depressed or not, or more depressed. I'm just going to see how you're doing. What has changed? I think that's the biggest thing that I try to tell girls is I want you to come back and see me if anything changes that you're worried about. Period. Because then they're going to come back if they have a good relationship with you and trust your health educator. So.
You know, mood swings are different. It's in depression. Because I know I get moody when I'm on my period. You know, I can tell. And I'm sure a lot of people, that way. So you try to kind of figure out, is it really the devil? Like, sit down. Because if it is, the doc's taking you off. He's going to put you on OCD. So we need to really talk about this and try to figure out. And if you think it is a devil, let's get off. Is what I tell them.
right. You're absolutely right. And so for the people on streaming live, she just made the comment that even when women get on their period, that sometimes they get mood swings, right? And so really identifying, is it severe enough to pull you off the method? And is it the method itself? Let's do some exploring before we automatically pull the method.
Or even again, like we've been discussing, that would be a point where I might send them to the mental health therapist just to kind of say, okay, let's just talk about your moods and that type of thing. And they're really good. Or like we use the PHQ-9. That's going to really tell me, is this a mood swing or is this a true clinical depression?
Any last questions? There's time for a couple more.
So what about using the sub-Q Depo that's half the dose of the, are you guys using sub-Q or do you still use IM?
Well, we don't use anything because we only have one school doing it. Unfortunately, hopefully that will change. And the community health centers that we refer to are not using the sub-Q Depo. But that's a very excellent point because the amount of progesterone is much lower.
Yeah, that's a great point. I want to thank all of you so much for participating. I hope that you are leaving here with some new thoughts. That's what we were planting the seed, and we wanted to grow into awareness and have that as your takeaway. So if you have any other questions, Wanda and I will be up here to answer any of those, and you guys have a fantastic evening.
Thank you for sticking
around.
around.
Thank you so much.